The information in this podcast is provided for informational purposes only. You should not use any information discussed in this podcast and related materials to make medical or healthcare related decisions. Always consult your physician or other qualified healthcare provider with regards to diagnosing and managing your medical condition. Any medications or treatments, including any discussed in this podcast, should be initiated and managed by a qualified healthcare professional. Welcome to Long COVID The Answers. Today's episode is the economic cost of long COVID. I would like to introduce you all to Professor David Cutler, the Otto Eckstein Professor of Applied Economics at Harvard University in the USA. Professor Cutler served on the Council of Economic Advisors and the National Economic Council during the Clinton administration, and has advised the presidential campaigns of Bill Bradley, John Kerry, and Barack Obama, as well as being senior healthcare advisor for the Obama presidential campaign. Currently, Professor Cutler is a research associate at the National Bureau of Economic Research and a member of the National Academy of Medicine in the USA. Welcome.
Thank you. It's great to be with you.
David, do you have any conflicts of interest that you want to declare?
I don't have any conflicts of interest related to the long COVID issue at all.
Great. And out of interest, what is an Otto Eckstein Professor?
So that's the name of the professorship. Otto Eckstein was a very famous economist, and his work was about learning from data about the economy. He developed one of the first macroeconomic models of the economy. So in many ways, this is quite fitting because I believe that he would have been very interested in issues like how does disease, and in particular long COVID, affect the economy?
Thank you for that. This podcast interview is based around the widely cited articles that Professor Cutler has written, namely the COVID-19 pandemic and the $16 trillion virus, a viewpoint published in the Journal of the American Medical Association, also known as JAMA, in October 2020, and his article, The Costs of Long COVID, published in JAMA Health Forum in July 2022. And as listeners should know by now, the links to all articles will be provided with the podcast. Professor Cutler, what inspired you to write both of these articles?
Of course, COVID was an enormous health shock, but it was also a huge economic shock. And so part of what inspired me to write these was wanting to get some sense about how big was the economic shock of COVID. Not that it was bigger than the health shock, but it has enormous implications for the economy. And so I thought that it would be interesting to explore them. And just as with medical care, where there's not like a single number you can say, okay, this is the number that is the health impact. There's not a single number you can say, okay, this to the dollars and cents is the cost of COVID. But it helps to get a scale for how big it is. Is it really big? Is it moderately big? Is it not so big? And that can then influence what policy actions are appropriate now or to prevent future potential pandemics.
Yeah, great work. Before we move on to examine your findings, I'd like you to provide a definition of QALYs, or quality adjusted life years, for our audience, as I believe this will help people who aren't familiar with the term.
So when we think about how much a disease affects people's health, you want to say, well, how does it affect both the length of life, that is how long they can expect to live, and the quality of those years? So will they be high quality or low quality? So for example, a disease that improves quality of life counts towards a higher value of life, even if it doesn't extend life. What the quality concept does, people always abbreviate it QALY, or often abbreviate it QALY, is it takes the remaining years of life, so life years, and then it adjusts them for the likely quality of those lives. In a case like COVID or long COVID, that's particularly important because it has both implications for the length of life and implications for the quality of life. And so what I do in both of these papers is I try and say how much is, in one case COVID, in the other case long COVID, likely to affect the quality adjusted life years, or the years of life adjusted for the quality of those years that people have.
Thank you. Could you please explain to the audience what a statistical life is and how it is calculated?
Yes. So qualities are in years, like how many years of quality adjusted life can I expect to have?
Mm.
If I want to add up different kinds of economic costs associated with long COVID or with COVID, so some of the costs are economic costs, like people are not working. Some are medical costs, like the money we're not spending on medical care, or the money we are spending on medical care. So it's very hard to add up dollars on medical care with years of life lost. So I need some way to value those years of life in dollars so then I can add up everything in dollars and get a dollar total. The way that economists typically do that is they ask the question, how much would a typical person be willing to pay to reduce the risk of disease? So
Mm.
a classic example would be, how much would I be willing to pay for an airbag in a car? And
Mm.
an airbag is not for sure going to save my life, but with some probability it will save my life.
Mm.
And so from that, I can get an estimate about how much people value kind of statistical lives. That is, I know it'll save the life of 1 in 10,000 drivers. I don't know who that one will be, but how much am I willing to pay to save the life of 1 in 10,000 drivers? That's not too dissimilar from how much would I be willing to pay to prevent a disease that would kill 1 in 10,000 people.
Mm.
So the statistical life is basically saying, okay, how much are people willing to pay, given their incomes, to reduce the probability that a typical person would die or suffer a quality of life impairment, and then value changes in quality of life, like, for example, the impact of long COVID on quality of life, by that statistical value of a life.
Current estimated number of people suffering from long COVID in the US is thought to be around 5.3% of the population at approximately 18 million cases. Can you please explain the estimated loss to the economy in terms of a statistical life and QALY with these figures?
Yeah. So you had the figures about exactly right, which is roughly 5%, about 5% of Americans are currently suffering from long COVID. In terms of the economic aspect of long COVID for the economy as a whole, I divided it into three parts. The first is the lost health, that is, people living longer and less long and lower quality years. And I valued those using the methodology we were talking about with the value of a statistical life. The second is people who are unable to work as much or as productively as they were.
Mm.
So
Mm.
people who are out of the labor force more, who are not as productive on the job, is the second part. And then the third part is the additional medical spending associated with caring for people with long COVID, which I guess would be like spending on chronic fatigue syndrome, which is a common manifestation similar to long COVID. So what I did was I took all the long COVID cases we knew of as of, say, a couple of years ago, and then said, how much would that, if you play it out over people's remaining lives, how much would that cost the economy? And the answer to that was about $3.7 trillion. That was the cost just of cases up to about a year or so ago, was
Gosh.
$3.7 trillion. And it was the sum of those three components.
Yeah, and a couple of years ago, the number of people with long COVID was 9 million, wasn't it? So are we looking at double $3.7 trillion now?
That would lead to it being higher. There are also other things that are important, like, for example, how long will people live with long COVID?
Mm.
That, I think the answers are coming in a little bit less long than we had feared, which is good news. That is, people seem to be recovering from long COVID on average a little bit faster than we had thought. So there are things that are turning out, obviously, to be different than what one forecast, probably on both sides.
But I spoke to Professor Danny Ortman recently, and the number of people suffering from long COVID in a population, I guess he's mostly looking at the UK, seems to stay the same, though paradoxically in America it seems to have gone up. So therefore, if people are getting better truly, and I don't know if we have true figures for that, because at the moment, the reason for this whole podcast series is because the medical profession knows very little about it. My day-to-day colleagues and friends who are GPs know very little about it. I think that it's very underdiagnosed. there's not enough adequate treatment. So people stop asking their doctors, they stop coming to us for help because we've not been very forthcoming. I don't know whether people are recovering or just simply no longer reporting. But the second thing is that new people are joining the ranks, so the numbers seem to be staying the same. I don't know whether there's been any studies to indicate whether people, they've gone back to work, maybe not working as much or as efficiently as they did, but now feel that they're good enough. And about 40% of people seem to not get better. And if we look at SARS-CoV-1, the study done in Canada, the vast majority of people that developed long COVID from that never got better. How do you feel about that?
So the estimates are very, very hard to know. As you said,
Mm,
in the US, the best data that we have comes from the Household Pulse Survey.
mm,
And that data asks people, have you ever experienced symptoms of long COVID, which it defines for them as symptoms lasting beyond when you had COVID? And then are you currently experiencing symptoms of long COVID? So about 15% of Americans say they've ever had symptoms of long COVID, American adults. And
mm,
about 5% of American adults say they're currently experiencing symptoms. So
mm,
if you take those at face value, about 2/3 of American adults who ever experienced long COVID then have recovered from it in that they say they're not currently experiencing.
true.
That rate of recovery over about 2 years or so. When I had done those forecasts, I guessed based partly on SARS-CoV-1 that the average case would last about 5 years. And so here, I think the average case is coming in below 5 years. So as I said, a little bit of data suggests that was too pessimistic an assumption.
Mm,
But
okay.
of course, both the data are subject to biases in reporting, and it may differ for different kinds of people in different settings and so on. So just to come back, the truth is very hard to know
Mm,
here. But Lord willing, hopefully people are recovering faster than at least I had feared they would
mm.
recover.
But sorry to go on
Uh-huh.
about this point, but the numbers have gone up from 2 years ago, from 9
Yeah.
million to 18.
Mhm.
So what's the reflection on
Mhm.
that with regards to your figures?
Yeah, people come into the population of having it as they have COVID. And so as more and more people get re-exposed or exposed the first time to COVID, that adds to the share of people with long COVID. So it's kind of, there's a flow in, and think of it like a bathtub. There's a flow in and a flow out. And the
Okay.
water comes in and then the water goes down. And so when the total amount is going up, then there's more water coming in than there is water going down, which is unfortunate. That
Mm,
doesn't tell you how rapidly the flow is going down, which is what you want to know in terms of how rapidly people are recovering from long COVID.
okay. I guess we'll know that over years to come.
Hopefully, if we get some good population studies of it, the UK has very good studies and the US are okay, but hopefully as we get better studies, we'll really get a good handle. And there's also, recovery is not just a 0-1, of course. It's I can work some, but I can't work fully.
Mm,
And I'm not as bad as I was, but I'm not as good as I was before COVID either. So it's not a 0-1 process either.
mm, okay. People who suffer from long COVID work and earn less, and the majority of sufferers in the Western world are working aged women between the ages of 36 and 50 years. What effects do you believe this has on the labour force as a whole and the healthcare labour force in particular?
It's a very good question. It has a very big impact. One of the things that we've seen in the US that has been seen in other countries as well is we're having a lot of difficulty staffing service jobs. So these are jobs like restaurants and cafes and hotels and medical care because it's an in-person kind of job. And of course, a lot of the medical care labor force is female. And a fair amount of the service sector labor force, from hotels to medical care to education and so on, would have been at higher risk for COVID because of the in-person nature of the contact. So at least in the US and I think in other countries, there's a part of, if you will, the missing labor force
Mm.
which is likely to be people who had COVID and developed long COVID who are then out of the labor force. Or they don't have it, but someone in their family does and they're caring for them. Or they're doing other things to offset someone having long COVID. And so that was really, really bad in the US probably about a year to 2 years ago. It's eased somewhat as people who had been burned out and discouraged have come back in the labor force. But there still is likely a decline. You still find that restaurants, hotels, many healthcare sectors, particularly the long-term care sector, still having a lot of difficulty hiring workers. And those are probably some people who are out with long COVID. Not all, there are many, many other things that are going on, but at least one of them is probably long COVID shrinking the labor force.
Important point. Could we talk about the potential loss of income as a result of that?
Yes, the loss of income is very severe and it matters in two ways. The first is to the family itself. So the family loses the paycheck that was coming in or part of the paycheck that was coming in. In most countries, there is some type of social insurance system to offset that. So it may have been the direct stimulus payments during COVID, would be a disability insurance program in other contexts. In other countries, it would be temporary disability in the US or permanent disability, depending on the nature of the illness. So the family loses money, part of which is offset by the social insurance system.
Mm.
For society, the loss is the fact that you've lost the person's income. And so when we were talking about the cost of COVID, I mentioned that part of the cost of COVID were the lost productivity. The other parts, the disability insurance and so on, those are transfers from some people who thankfully are still working and healthy to other people who are not in the labor force, either for long COVID or for other reasons. Those transfers don't reduce GDP. They don't affect how much total there is in the economy, but they take money from some people and give it to others. The total social loss is the fact that there are people who would like to work, who were able to work, who now no longer can.
What concerns me is that we've got in the West an aging population, and I know at some point, if it hasn't happened already, two-thirds of adults will be over 55 in Europe, and I presume North America and the rest of the West. And we're losing a whole huge proportion of people that can't work in because they're suffering from long COVID and therefore not contributing tax dollars to sustain our economy. So what do you think all of this will have with regards to our aging population on our economies?
Yeah, so most Western countries, the US is on the least end of this, but all Western countries are aging quite rapidly. And so finding ways to keep people at work longer was a big deal before COVID and is now an even bigger deal afterwards. One of the things that is helpful about COVID is that remote work has opened a lot of possibilities.
Mm.
So for people who could only work part-time before, remote work enables them to work more part-time. And for many people who were disabled and out of the labor force because commuting to work was very difficult, telework jobs make it be possible to go back to work. So ironically, one of the things that we've seen in terms of increased labor supply is that people with disabilities are more likely to be at work now than they were before COVID. All of which is to say that the employment situation has both an ability to work, that is, can you work, and is the labor market set up so that you can work?
Mm.
And one of the big issues for employers is finding ways that people with long COVID or other conditions can still meaningfully work, even if they can't do, if you will, 100%. One example of that is, some employers require some mobility at work. Okay, fine. So one of the common stories that I hear is people with long COVID who have difficulty climbing stairs. Well, so maybe you can reconfigure the job so that that person doesn't have to climb stairs.
Mm.
And someone else can do the climbing of the stairs, or there's some other way to get things up and down the stairs. once you make that change, it's not a big change, but once you make that change, all of a sudden you've now increased someone's ability to do the job. And so those kinds of accommodations are going to become really crucial. They've become crucial because of COVID and long COVID. And continuing up with that is going to be really crucial so that we're able to maximize the productivity of everyone who can work.
That's a really excellent point, and something positive that's come out of this horrible pandemic, that we're having to now think about disabled people more, because long COVID sufferers, a lot of them are disabled. And so therefore, maybe we'll be able to bring people that were disabled, who weren't able to work, into the workforce if employers are properly supported to do so. That's a really good perspective and something positive.
It is. So, I try and look for the silver lining in some of this, but it
Mm.
really is that if you can do something from home now and you can save 2 hours of commuting time and a very difficult commute for some people, that's going to allow some people to work who would not have otherwise been able to. And that's a great thing for them, their family, and society.
Yeah, yeah, that's good. Can you talk a little bit more about the medical costs of treating long COVID?
Yeah, the medical sector is not very well set up in the US, as in most countries, to treat long COVID. Chronic fatigue syndrome, which is probably the closest, the sort of feeling that you're in a fog and so on. In the US, we used to dismiss it with the term yuppie fever.
Mm.
So that was yuppies working too hard and so on. Of course, now what we've learned is that it's not yuppie fever. It's a very serious condition. And of course, long COVID is a very serious condition. The medical system is not very well set up to treat people with long COVID. Now, in part, there are different manifestations of long COVID. So sometimes it shows up in the cardiovascular system, and so you need cardiologists, or the respiratory system, and you need pulmonologists, or so on. But then sometimes it's in the realm of primary care. And what we need is primary care doctors who feel as comfortable treating long COVID as they do treating diabetes, or let me call it minor mental illnesses that are reasonably standard in primary care. So some people need to be sent on to a specialist because the situation is very bad, but others can be treated in primary care. And the problem with having just specialists is there's no way to get enough of them.
Mm.
If every person with diabetes needed to see a cardiologist, we would run out of cardiologists well before we had exhausted the population in every country. So you have to be able to treat people at the primary care level, at least as long as you can manage that. And so the medical system is going to have to get to a point where primary care doctors and nurses and so on feel comfortable treating many cases of long COVID, not all of them, because very severe cases are going to have to go to specialists, but many cases of long COVID need to be able to be treated in primary care.
Yeah, that's an excellent point. And I guess that will keep costs down. The whole point of this podcast series is that I've spoken to colleagues across the board, and they just really don't have any idea of how to approach it. We've been talking about this in Canada, and it's become apparent to me as a family physician that we need a multidisciplinary setup in primary care. At the moment, everything's dumped on the family physician. You're a social worker, you're a psychiatrist, you're a multiple specialist. There's just so much complexity, often expected in 7 to 10 minute consultations. And long COVID sufferers need more time, and they need that multidisciplinary support, say with a nurse, an occupational therapist, a social worker, a physiotherapist working in conjunction with us. That's where general practice needs to change. How do you think about that?
Almost everything consequential in life is done by teams, not individuals.
Mm.
Sports are team sports, not individual sports. Innovation, design, new scientific knowledge is done by teams, not just by individuals. The idea of the lone individual sitting in their lab discovering something is not true now, even if it ever was true, and I'm not sure it ever was true. So the whole idea of medicine has to be around the idea of the team helping to care for people, not the individual doctor whose responsibility it is. For some things, the doctor can be fine, but that doctor needs to be able to have a team in place, as you mentioned, psychiatrists, behavioral health workers, nurse practitioners for the less severe cases, specialists for the more severe cases. And that team has to be able to function together. And the worry is that if you dump it all on one doctor, that one doctor just literally can't handle it all. And so things are going to fall through the cracks. So I am a very, very big believer that medicine has to be done in a team fashion. And long COVID, I think, brings that out in many ways because the symptoms can be all over the map.
Mm.
And so you really can't, no one is going to be an expert in all of those symptoms. Or conversely, if you're an expert in long COVID, there's just no way you can see all the patients who need to be seen. So you've got to have a teamwork approach to this. And that's what the good health systems will do, is to try to figure out how do we bring all of our resources together at the right time and the right specialization to care for the patient, not just how do I get this one doctor to do it.
David, you just make such excellent points, and you've given me a really positive angle on looking at this. We could really, if long COVID was properly recognized and taken seriously in the medical profession, it could help change the whole way primary care is delivered that will benefit all. This is something I've been harping on about for ages, and what is really driving people in my profession out of it, because everything's dumped on one individual. And I think we're partially to blame for that in trying to be heroes. But then again, everything's changed from the 50s to now. There's just so much more you can do in medicine, and primary care just quite hasn't caught up. But yeah, thank you for those excellent points. What are your thoughts on how we can reduce the massive economic losses you've attributed to long COVID?
A couple of points about what we can do. One is, as we were talking about, employers can help by trying to reconfigure jobs, using people who can only do telework through telework, figuring out what people can do and having them do that as opposed to insisting they do things they can't do. The second responsibility is the government's responsibility, and that is to do lots of more research on how people with long COVID are faring and what kinds of therapies would be helpful and what sequencing of things and so on will be most helpful. So population studies combined with biomedical studies to learn about the best ways of treating long COVID. Third is, as we were talking about the medical system, and the medical system has to think about how it as a system wants to address long COVID, not just how each individual clinician wants to address long COVID, because there's no way that any individual clinician can just add that on top of what they were doing and expect to be able to do a good job.
Excellent point.
And I would say the fourth issue is, because the costs of long COVID are so big, as are the costs of acute COVID, we need to do everything we can to prevent recurrent epidemics. And that means investing worldwide in the kinds of things that will lead to healthier populations, less likelihood of infectious disease spreading, earlier notification when it does, more actions to help prevent people. So on some things we did very well, like developing vaccines quickly, other things we did awfully in terms of preparing populations and so on. So learning from this so that the next time we don't face this situation again is another important area.
Yeah, thank you. Why do you think governments around the world are ignoring the economic impacts of long COVID?
It's interesting because people got so focused on the death totals from COVID, right? You know, how many people were dying of COVID. And then when those numbers went down, people had a tendency to want to forget that the people who survived were not all the same as they were before. And then, at least in the States, it got caught up in this sort of political issue about, did we overreact? And so if you have, for whatever reason, the political orientation that we overreacted, then saying, well, no, long COVID is a big deal, it doesn't fit with that. So between the focus on the acute disease, which at the time was appropriate, but not the exclusive focus, and the sense of, oh, no, I need to show that I'm in favor of the economy and not what the public health practitioners say, all of that conspires to push long COVID to the back. And then I think the biomedical research folks in the medical system have not stepped up to say, no, 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 you can't do this to long COVID any more than you can say to people who are living with AIDS, tough luck, who are HIV positive, tough luck, we don't care about you anymore. Like we understand you can't do that for people who are HIV positive, but we haven't reached the same place for people with long COVID.
Mm. Yeah. Learning about this disease has really opened my eyes to others and made me rethink about other post-viral illnesses. And I didn't even realize that HIV had a whole swathe of post-viral illnesses.
No.
So hopefully myself and others and yourself are trying to wake up the medical profession to acknowledge that.
At
Um,
least in the US, we have been much better about caring for people with HIV because we understand they
mm,
need to be on lifelong medication and we have programs to do that and so on. But, even still, there's this tendency to want to say, oh, no, let's forget, we don't need to worry about this disease anymore, when that's just not true.
mm. In the beginning of your 2020 article, The COVID-19 Pandemic and the $16 trillion Virus, you state that the SARS-CoV-2 pandemic is the greatest threat to prosperity and well-being the US has encountered since the Great Depression. You also state that your figures are based on the optimistic assumption that it will be substantially contained by the fall of 2021. Given that we are in the second biggest wave of coronavirus infections due to the variant JN1, currently estimated in the US alone as 2 million per day, causing approximately 7,000 to 8,000 deaths per month in the US, what do you think the true cost of this pandemic is now?
It's interesting, like what we were talking about with long COVID, there have been some things that have been worse than we forecast and some things that have been better. So the things that have been worse is, of course, the disease keeps going on and we're in the midst of another wave now, and God knows how many more there will be, and that's just horrible. The thing that's better is the US did not go through a very prolonged slump because of COVID. So unlike in, say, 2010, when the economy spiraled and we went through a very long recession, very tough recession, the Great Recession, people call it. Here, there was certainly some adjustment problems, but actually the economy has done very well.
Mm.
And credit to fiscal authorities, credit to monetary authorities that have done a much better job here than they had done in the past. So I don't have an updated number in my mind for what the number is now. Unfortunately, COVID is still around, but fortunately, our management of the economic consequences of COVID has been better than I had feared it would be.
That's interesting. Okay, so I know we've run out of time. We could probably go on for another hour. You brought up so many interesting topics. I hope you'll come back for interview when you republish or update on this whole topic, because we'd love to speak to you again. Your articles have been, as I say, widely cited in other research papers. I just constantly kept popping up. That's why I wanted to invite you. Thank you for your very excellent work.
Thank you
And
for having me.
oh no, it's been a pleasure and an honor, Professor Cutler. Please keep up the just very excellent work.
Thank you. Thank you so much.
Some questions for listeners to consider. What are your top 5 takeaways for this episode? How will this episode change your practice or perception of this disease? What will you do to act on what you've learned? Please discuss your thoughts on our social media outlets, Twitter or X, the website blog, Instagram, Facebook, or LinkedIn. Please rate this episode.